Hello and welcome to Healthcare Matters, the internet television program that explores the intersection of medicine and the law. I'm your host, Mike Matre, and today's guest is Dr. Richard Anderson. Dr. Anderson is the Chairman and Chief Executive Officer of the Doctors Company, the nation's largest physician-owned medical malpractice insurer. Welcome to the program, Dr. Anderson.
Thank you very much. Nice to be here.
Recently, the BMJ, the International Peer-Reviewed Medical Journal, published a study of Florida physicians where it correlated that physicians who spend more money conducting tests and procedures for patients were less likely to be sued for medical negligence. Do you agree with the premises of the article, and why?
Yeah, it's a very interesting study, and I think a very valuable one and an important one because defensive medicine has been I think, sadly underappreciated from the point of view of medical research, the medical research community, and also terribly underappreciated from the point of view of policymakers and those who have to create healthcare law, as well as those who have to pay for the cost of healthcare in the United States. So I certainly commend the authors in a very serious way for making an important contribution. I think there's several truths that emerge from this paper, and then several areas of concern as well. One of the truths is that physicians believe in defensive medicine. In other words, physicians believe when they order additional studies that are, again, think back to what my definition of defensive medicine is. Definition of defensive medicine is a test or procedure or therapy that's ordered primarily to reduce the liability of the physician rather than to benefit the patient. So again, by definition, what we're saying is the physician believes that it will reduce liability. So it's not surprising, and what this study validates, it really validates the notion, the data in the study validates that notion, that physicians strongly believe that defensive medicine reduces liability. Now, the second point of the paper is that using a very sophisticated statistical analysis, the authors found data that they believe supports the notion that defensive medicine does reduce liability. And here, I'm not so sure that that's true. Again, if you take my definition of defensive medicine, it can't be true. In other words, if it was the right test or therapy to order in the first place, then it wasn't defensive. So then ordering a test that isn't the right treatment is not going to reduce your liability. So almost by definition, what they say can't be true. But I think it shows how difficult it is to separate all of these factors out. And it also shows that physicians believe that more test ordering and more therapies and so forth reduce their liability profile. The authors quite appropriately themselves make the point that they're unable to evaluate the acuity, in other words, the degree of illness of the patients from the 1 year to the next. We're only doing a 1 year, a year over year, but only 2 year comparison. And so the data, I think the data is challenging. They use C-section as an example of this same notion, and C-section is a very interesting thing to look at in terms of defensive medicine because I think it's universally acknowledged by both public policymakers and physicians and obstetricians that we do too many C-sections in the United States, and that too many can be defined almost any way that you like. Too many because they're too expensive. Too many because a C-section that isn't necessary is without question riskier on the average than a normal vaginal delivery. But also we have international data. The United States does about twice as many C-sections as any other first world country. If C-sections were just generically produced better outcomes, then we would have better birth outcomes than other first world countries, and the truth is we don't. And so it's really clear beyond a shadow of a doubt that once you get beyond the necessary threshold, and interestingly enough, there is some data that would suggest that roughly 15% of deliveries ought to be C-section using modern medical standards of care. In the United States, that number is closer to 35%. So really very, very high. The authors themselves make a very interesting point, which is that C-section rates in the United States have increased by 60%, 60% since 1996. So basically, in the course of 2 decades, there's a 60% increase in the number of C-sections. Now, if you sort of think about that, it's basically physically impossible for the characteristics of the human pelvis and the human gestation process to have changed to circumstances where a 60% increase in the number of C-sections could ever have been medically mandated. And what it points out, and again, this is very fundamental to my belief and to this point that I've been preaching really for many years, is that medical standards of care in the United States have been polluted by medical legal standards of care. In fact, most standards of care that purport to be medical, and should be medical, of course, are in fact medical legal standards of care. And in the United States, I think it's really easy to argue that the medical legal standard of care induces a C-section rate that's probably 25 or 30%, as opposed to what is more likely, whereas a medical standard of care would probably produce a C-section rate a lot closer to 15%.
Dr. Anderson, thank you for taking the time to visit with us today.
Well, thank you very much. It was a great pleasure. Thank you.
In the healthcare industry's quest to reduce the overall cost of medical liability system, experts have recommended a number of alternative dispute resolution structures. They range from mediation and arbitration to specialized health courts. How do you feel about these alternative dispute resolution ideas, and do you endorse any of them?